So our next presenter is Dr. Leslie Skees from Calgary, and she's presenting on the Prep and Go project. Leslie, up to you.
Hi, Dragons. I'm Leslie Skeeth.
Isabelle Malamé.
And together, on behalf of our investigators, we are presenting Prep and Go, a peripartum anticoagulation management study. Let's cut to the chase and the bottom line. Dragons, we are asking for $40,000 to complete an economic analysis sub-study of Prep and Go, as well as having additional funding for our US site. And what will you get in return? What's your return on investment? You will be able to strengthen 5 research networks across 13 sites for this CIHR-funded study, and we will help you advance the Verdict online adjudication platform hosted by CanVector and supported by Invent by helping to build new ISTH peripartum bleeding definitions into the platform. Because there could be different anticoagulation management strategies by physicians, we will also take an innovative approach to your platform and actually adjudicate the individual strategies so we can classify them and categorize them for analysis.
So of course, to inform decision-making surrounding peripartum anticoagulation, we will have to take into consideration thrombosis risks, bleeding risks, and patient preferences. But at the end of the day, maybe none of these can be implemented if your healthcare systems cannot withstand it. And so it is crucial to understand resource utilization associated with each anticoagulation strategies because cost matters.
Prep and Go is a pragmatic, unique, prospective cohort of pregnant women on low molecular weight heparin for either a VTE or those at risk of VTE, such as a potent thrombophilia. We will be systematically tracking our participants throughout labor and delivery, as well as the immediate, early, and late postpartum periods. Our study also includes patient questionnaires, pre and post-delivery, as well as blood work, including a CBC and anti-10A level. This is pragmatic. We have the option of doing postpartum visits by phone at 6 weeks and 90 days.
Our primary outcome will focus on the combined incidence of major bleeding and clinically relevant non-major bleeding for up to 6 weeks postpartum. Importantly, we will be featuring for a first time the new ISTH peripartum bleeding definition, which has been developed by members of our team. This novel outcome will be adjudicated among 825 women recruited from 13 participating centers across 6 countries.
This study and this sub-study is really about healthcare utilization. We will be collecting resources available at each of the centers, as well as data relating to length of stay, postpartum and total hospital length of stay, induction of labor, repeat procedures, and rehospitalizations. If there are differences in resource utilization across different anticoagulation management strategies, we will be completing a cost analysis based on published cost data. If there are clinical outcomes that differ across management strategies, we will be completing a cost effectiveness analysis. And this is where we need your help and your funds to support additional statistical and database support. We have the perfect person for the job. Our collaborator, Dr. Jeff Fetterspiel from Duke University, is the triple threat. He's an obstetrician, maternal fetal medicine specialist. He has training in thrombosis under the mentorship of Dr. Andrew James, and he has a PhD training and experience in healthcare utilization and cost effectiveness analysis.
So Dragons, we will provide you with accurate information on the risk of VTE, peripartum bleeding, and patient preferences around labor and delivery. Importantly, we will get to understand how best to optimize care to benefit the most people. Now back to you, Leslie, for concluding remarks.
In summary, we will provide you with high-quality data to implement patient-focused decision-making in your healthcare system. And Dragons, we are ready to take your questions.
And your offers.
Thank you, Dr. Malame and Dr. Skeeth. And Dragons, the floor is yours.
Okay, so maybe I'll go first this time, if that's okay with you, Dr. Noble. So Leslie Skeeth and Isabel Malame, very persuasive presentation. And Leslie, we all know that you're the master at study acronyms. So you found another good one here. And thanks for reminding us, Dragons, that cost matters. We are asked to judge whether studies will change practice. So please let us know, in what way do you anticipate that this descriptive study will have implications for clinical practice?
We really have a lot of practice variation across centers, across the world around anticoagulation management, around delivery, in part due to very limited and retrospective data that has different definitions of bleeding and how this bleeding was collected. And in the future, we will be planning a future randomized controlled trial. But really our first step is to get that data and get the information to the hands of patients and providers. And so by tracking and using standard and now new definitions of bleeding, our VTE definitions, and really incorporating and understanding patient preference and healthcare utilization, we think this is a next big step for giving information on what strategies may be acceptable or not acceptable based on standardized data.
In addition, if I may add, anticoagulation practices surrounding the peripartum period are intimately linked to the management of delivery, and from an obstetrical standpoint, the management of the DVT risk or the actual DVT may have an impact on healthcare utilization in the obstetric setting. And so this will be a holistic approach to understanding anticoagulation strategies in light of the global system in which the patient is in.
Great. In the interest of time, I'll pass on to Dr. Noble. Thank you.
Thank you both for that very slick presentation. I'm interested to know a bit more about this questionnaire, which is going to evaluate patient preference.
It's a great question. We have developed the questionnaires.
I'm a dragon with good questions, you see.
Excellent question, Dragon.
Good.
We have a pre-delivery questionnaire, which in part is about expectations and choice. We will have a direct choice question because there are competing risks of epidural use versus bleeding risk and VTE risk. So we do have a little bit more focus on those different options. And then postpartum, more focus on satisfaction, what happened, and that expectation around what happened around labor and delivery and matching it with their expectations.
So how's this been designed? What are the processes that have led to this being designed? We've not pulled off the shelf some standard questionnaire here.
There is no no questionnaire that has been previously studied. So our first step has been to develop it with our group, with input from 2 patient partners, and we will be piloting this questionnaire and potentially going into a little bit more detail relating to interview or to kind of the pilot walkthrough of the questionnaire to test it out.
Okay, thank you. Final question from me. You're talking about doing health economic analysis. Within the United Kingdom, when decisions are made about various interventions, the health economic analysis will actually have a threshold number of quality adjusted life years for it to be considered financially viable. Do you have such a target from a health economics perspective in your study?
I think one of the challenges and the benefits of doing an international study is that we will complete a cost effectiveness analysis, but look at it with a different lens depending on the country. For example, Canada versus US or the UK or Europe or may have differences. So we will be looking at that. That cut point of the 50 to 100,000 QALYs may differ across countries and across institutions. So we will have one, but look at these different metrics according to the country.
Again, one of you buggers goes on about the UK and Europe. Stop rubbing it in. It's not my fault. We made a mistake. They made a mistake. Bloody hell. It's just not fair. Don't you do that to me, Dr. Khan, you meanie.
All right, any question from the audience? Not that I can see any. Suzanne, any final word before we move on? Are you good? Good, great. Well, thank you, Dr. Malame and Dr. Skeet then, and for your presentation, and we'll